Okay.
Good to go, ma'am.
Okay. All right. So today we are going to have a continuation of the last session. And today we are going to talk about collusion and we are going to talk about breaking the bad news. Yes. So first of all, let's look at what collusion is, how it affects, and what to be done in such cases. Collusion basically usually occurs when the family is conspiring among themselves or with professionals to withhold information or lie to the patient, especially about the diagnosis. Now, most of the times, it's usually well-intentioned. It's not that they're doing it out of a will to harm the person. It's actually with a good intention that they're doing it because they are acting in what's believed to be the best interest of the patient, according to them, to protect the patient from emotional harm. But what happens is this usually creates tension when the patient wants to know the truth and has the right to information. So collusion must be addressed when it is hindering good quality care, when it's leading to futile interventions, which we know are not going to help. But just because there's collusion, just because the patient doesn't know that, know the prognosis, we keep on having to do futile interventions. That is when collusion has to be addressed and when it becomes harmful to the patient, basically. So how to do that? How do we manage collusion though? Firstly, we need to let the relatives know that we are on their side. Okay, it shouldn't be that we get into arguments constantly and they start thinking of us as their enemies. So we need to convey to them that we are on their side. Don't start by trying to prove how they are being wrong when they're colluding. Instead, take an approach where you validate the intent behind their actions. Their actions might be wrong, but the intent with which they're doing is definitely care and concern to the patient. So validate that. Let them know that, you could say something, for example, like what I've put on the slide, you want the best for your mother. So you're validating their intent behind what they're doing. And let them know that you are on their side. So you could say something like, I also wanted the best for her. So let us talk about it and make a plan of how to go about it. Post this, you can start by exploring what is the family's understanding, what are their insights about the illness, what is their reasoning, basically. So the reasoning behind why they are doing this is very important. They might be doing it for multiple reasons. Now, they might be doing it, we need to establish whether they are trying to protect themselves or the patient. It is also quite possible that they are not very comfortable facing the emotional consequences of telling the patient, and that is why they are trying to collude. Or it's not always that this is the case. There are also cases where there are valid concerns, where they recognize that the patient's past behavior patterns or the patient's past coping mechanisms might be problematic in this situation. So we need to recognize that they might have these valid concerns about the patient's capabilities and behavior patterns. And we need to know it because it is also very, like, it's vital information for us as well if we are going to manage the patient properly. So that is the second part. And thirdly, we also need to identify whether they have a correct understanding of the clinical situation, or is it just out of misguided fear that they are trying to hide things from the patient. Thirdly, what we need to do is reassure. Once we know how much they know, once we know why they're doing what they're doing, what we can do is we can start by reassuring and explaining. So when I say reassure, what I mean is reassure that you are not going to just walk in on the patient and drop the truth like a bombshell, because that is what most of them are going to be afraid of. Once you've reassured that you're not going to do this, once you've reassured that you're not going to impose information on the patient if they don't want to know, start by finding out if the family has already felt adverse effects of withholding of information from the patient. This is going to be very important in helping them change their attitude towards being truthful to the patient. So when you explore about adverse effects, things like, has the patient been anxious? Has the patient been bargaining, making unrealistic demands about treatment, which the family knows is unrealistic, but the patient doesn't, because of collusion, because the patient doesn't really know what is possible and what's not possible. So asking such kinds of questions, finding out and eliciting it from them as to let them tell you what are the adverse effects that they have felt uh, because they have withheld information from the patient. Explore how much withholding information has affected the communication and interaction within their family as well, because it's not easy to keep hiding things from each other or from the patient. So has it affected the family dynamics and their interaction and communication? That's also something you need to explore. After which you can start explaining the consequences of keeping the diagnosis from the patient. At this stage, when you start telling the consequences, because they have already explored the adverse effects by themselves with your prompts, they are going to be in a state of mind where they're ready to hear all of that, and they will be in a mindset where they'll be more receptive to what you're telling them. Also mention that you recognize the patient's right to information if requested by the patient. They should also know this. And you can, of course, offer to facilitate the conversation between the family and patient if they are finding it too difficult to handle by themselves, or if they are finding it too difficult to manage, and that is why they are not telling the patient things. Then you can, of course, offer to facilitate. And still, if after all of this they are still unwilling, you can always get conditional permission to find out what the patient already knows. Okay, this is going to be a starting point. So you can always get permission for what just to find out what the patient already knows. I'm not going to tell the patient anything. I'm just going to ask what they know. Okay. Fourth step after this is to share information as it becomes necessary. Now, when you talk to the patient about what they know, most of them, I'll tell you, at least from my experience, most of them, especially in advanced stages of their illnesses, are very much aware of what is happening. They might not have the words for it, they might not know technically what's happening, but they're quite aware that something is not okay. And most of the times they do wish for further information and clarity. So explore the patient's understanding and assess if they wish to know more, they wish to have further information. If they say so, inform the family about the patient's wishes. You've already informed the family that if the patient wishes to do so, they have the right to. They have the right to information, and you can't deny them that. And once you've informed the family members about the patient's wishes, after that you can start sharing information. You don't have to just overload them, burden them with the information all together all at once. Share it in digestible chunks, small chunks. And when you've discussed with the patient, you also have to let the family members know what has been discussed with the patient, so that they don't know what to talk, what not to talk. None of that happens. They know all. They're basically all of you are on the same page. So keep the family in loop. And further, encourage open communication between the family and patient now that they all know everything. And if the situation demands clarifications or explanations further, you can always pitch in. Right? Now, occasionally what happens is the other way around. The patients know the diagnosis, and patients collude with professionals to withhold information from their family. So, things like, don't tell my mother about this, or don't tell my children about this. They won't be able to handle it. Such requests, when they come from patients, that is a slightly more difficult and a slightly dicey situation, mainly because if you are to disclose information to anybody other than the patient, you require the patient's permission to do so. But again, the principles of doing it stay the same. The same approach is to be taken, handling things sensitively, exploring the reasoning that the patient has for withholding that information from relatives or family, explaining about the consequences, reassuring, and offering facilitation. That is what we are going to do, regardless of, sorry, So this is what you're going to do regardless of who is colluding from whom. Yes, all right. Are there any questions about collusion so far?
Dr. Mukta,
Ma'am, your voice is breaking. Hello?
am I audible
Yeah.
now?
Yes.
Okay, just wanted to check with you. I had actually kind of started to ask you this question in my last session, in your last session, but somehow my internet did not allow me to.
Yeah.
This is whatever, and now also I've not joined dot on 3, but a little 5 minutes later. So my question, maybe it relates to the similar scenario. What if the patient is not in a state to understand, like, somebody with a dementia or somebody with the not the logical sense of the moment.
These are exceptional circumstances, of course.
Yeah, because in that case what happens, like we share it with the people who are the caregivers, the
Yes. Yes.
the details, right? So in that
Yes.
case, because like we were the caregivers for my father, for who's this thing I'm asking now he is no more. So the
Mhm.
doctors did not give us the details at all, like, till the third day, fourth day, and in 7 days he passed away.
Okay. Oh.
So
Oh.
logically, ethically, was that correct, and how it could have been done otherwise?
Yeah. No, given that there was dementia, given that, as you said, if he was not in any fit state to really give consent, so to
Get
say,
the information,
it was the
understand.
doctor's duty actually to let you know, as the primary caregivers, of course. Hello.
So in that case, like, because the patient cannot judge or this thing, like, what has to be. So that's a time when the caregiver steps in, and that is the person who has to be first informed. That's my answer, right? Meaning whoever
Yeah.
is a caregiver, so they should
Yeah.
have informed.
They should have
Yeah.
informed. They should have informed. Yes.
About the actual condition, because on the day 7 they are saying, "Ye to hame first day se pata tha, even we are knowing it since first." Then they did not inform us on the third day till he went into ICU and then into the ventilator. That's why. So that time the patient's cognition is not that supportive, is what the
Right.
thing is, and
Right.
that decision has to be taken on his behalf by the caregivers, right? So we
Right.
were on
Right.
track. Thank you.
Right. Yes. Okay. All right. Anybody else? Any doubts about pollution? Any clarifications? If not, we can move on. The next thing what we are going to see is about breaking bad news, and this is going to take the chunk of our time today. So, well, first of all, nobody likes having these conversations, right? They're difficult, they are uncomfortable. And today we are going to see how we can make them a little less difficult and try and understand how our patients can react and how we can respond in these situations. First of all, no one likes to be the one to deliver bad news. But it's also helpful to remember our aim in doing it. We are giving somebody a bad news, true, but we are doing it in the best possible way with the best possible intention so that it facilitates understanding of the situation, which itself helps people prepare themselves mentally for what is to come and not receive a shock, which I think Sheetal ma'am will absolutely agree based on what she just shared with us. At the same time, they also feel supported in their emotional response to the news because of the way we communicate it or the way we're supposed to communicate it. And here, the 7 steps which we had discussed in the last session are going to be very important as a general structure or framework for us to proceed. I'm just quickly reviewing them. The first thing was to build a relationship. Second was to open up the discussion with the patient and family. Thirdly was to gather information about what they already know and understand their perspective, after which we share information. And finally, we arrive at an agreement on the problems and the plans. And lastly, we close the discussion in a sensitive manner. Now, you will see these steps being repeated to an extent in the protocols, which we will touch upon. And so before I get into it, some of you might be wondering, do we really have to do this? Do we really have to break bad news? It is so uncomfortable. It is so disturbing. Do we have to do it? And why is it important? Why do we have to learn to do this? So firstly, sadly enough, in our professions, we have to do it quite frequently. So if we anyways have to do something stressful, why not be skilled at it? Rather than fumbling around and making it more stressful for all of us involved, right? So that's the first thing. Secondly, your patients want the truth, and it's your duty to give them that. So that is why we need to learn how to do it. Thirdly, there are of course ethical and legal obligations to let the patient know. And most importantly, how we do this has an impact on the clinical outcomes as well. So how we do this affects the patient's comprehension, their satisfaction with medical care, their level of hopefulness, and of course, subsequently, their psychological adjustment to everything, the entire condition and the process. Remember S from last session? Not knowing made her anxious, distressed, unhappy with her doctors. Knowing made things better. Right? So that is why it's important to learn how to break bad news. Now, again, just like there are barriers to communication, which we saw in the last session, of course, there are barriers to this difficult task of breaking the bad news. First and foremost, the one who is doing this is mostly stressed, right? Very obvious. If I ask one of you that you have to go tell a patient that we cannot offer any curative treatment and that their disease has reached a highly advanced stage and is progressing, how would you feel? Anybody? You can put your answers in the chat box if you want, or you can unmute and tell me how you feel.
Highly under stress.
Highly under stress.
Very,
Yes.
very stressed.
Mhm.
Yes. Because it is somebody else's thing that you have to convey to them. But it's an obligation too that you have to do it.
Right, right. Mansi, ma'am is saying uncomfortable, scared. Yes. So, of course, this coming from our own experiences and coming from our own feelings, studies also show that the bearer of bad news experiences strong, intense emotions like anxiety. It's a burden. And this stress makes us reluctant to break the news, especially if the patient is already in a not so good condition emotionally. Nobody wants to do it. And it's not just how it affects our patients, it's also about how it's affecting us when we are breaking the bad news. And secondly, we might feel unskilled in certain areas, like how do I handle the emotional outburst? How do I do this without taking away hope? What if I'm looked at negatively because I gave the news? What if the family starts hating me? All of these things. And again, as a consequence, if we are uncomfortable in delivering bad news, chances are we may avoid discussing some points altogether, which might be distressing to the patient or the family. Or in the bargain of giving hope, we might end up giving false hope and optimism. So having a strategy definitely make things easier. It eases off stress from our shoulders as well, lessening the chance of a burnout for us. So we are learning about this as much for us as for the patients. Let's do one thing. Let's go back in time, way back to the 1950s, 60s, and 70s. Doctors then actually considered it inhuman and damaging to the patient to disclose bad news. Of course, that was also a time when treatment prospects for illnesses like cancer were quite bleak. But by the time we reached late 1970s, most physicians had become more open to telling the diagnosis to the patient. But now patients were not really satisfied with that much. They had more questions. They wanted additional information. They wanted to know the prognosis. They wanted to know the side effects. They wanted to know how much time they realistically had in hand to live. Over the years, many studies in different parts of the world repeatedly showed the same thing, that patients wish to know. Then came issues of patient consent and patient autonomy, which gave a further push to openly communicating with the patient about the illness. But of course, the medical fraternity had to take into account that simply disclosing the truth without a concern for the sensitivity with which it had to be done or neglecting the duty to support patients through this and to help them take important decisions could have quite a negative impact on the patient. So we couldn't just overcompensate for years of hiding the truth with sudden insensitive truth telling. So people working in the field have over the years tried to come up with protocols that we train in and can follow in situations where they're required. Most of them are based on the underlying principle: before you tell, ask. Hence came spikes in the year 2000. Okay, which was first proposed by Bailey and colleagues in the context of cancer. One of the most well-known, many of you might have heard of it already. Spikes is a 6-step structure that can aid in delivering bad news to patients and families, and it has 4 main objectives. Firstly, sharing information with the patient. Secondly, gathering responses from them, providing vital support, and creating a plan to move forward. Right? These are the 4 goals of breaking the bad news. Looking at the spikes protocol, let's just look at it one by one. It's actually an acronym that stands for 5 different things. First is setting up the interview. So make sure you're doing it in a quiet, private space when you're going to break the bad news. If arranging a room is not possible, at least the least we could do is make sure the curtains around the bed are drawn. So don't do it standing somewhere in the lobby or in the corridors, and try and minimize distractions. Keep your phone on silent. If you're likely to get calls, if somebody is likely to come and get you for some other work, let the patient know beforehand. Involve significant others. Let the patient choose who they want with them. And when everyone is gathered, firstly, very important, sit down. This makes everyone as comfortable as possible. It also lets them know you're not rushing through this. You're giving it the time and space it deserves. Right? Also make connection with the patient. Have eye contact, a slight touch when necessary, if necessary, and manage your time and interruptions, and then get into the interview. Next is P for perception. So assessing patient's perception of the condition or the seriousness. Determine what the patient knows about the medical condition. What do they suspect? Here, make use of open-ended questions like we discussed in the last session. What do you know about your condition? What has the doctor told you so far? So my experiences, as I said, most patients are well aware of what's happening intuitively. So listen to their level of comprehension. What do they know? If there are any misconceptions, identify those. And if at all there is denial in the form of wishful thinking or unrealistic expectations of treatment outcomes, all of that, again, you'll be able to determine it, accept it, do not confront it at this stage. Thirdly, I is for invitation. Obtain patient invitation. Ask the patients if they wish to know the details of the condition or the treatment. Not everyone will want to know. Especially those who are scared can resort to the defense mechanism of shunning information. It helps them cope. So always ask if they want to know, and if they say no, accept their right to not know as well. But at the same time, don't close doors. This is not a now or never thing. You can always offer to answer questions later if they wish to do so. Right? So that is what you do. You let the patient invite you to give information. That's the third step. After this is K for knowledge. So if the patient says, yes, tell me, firstly, give a warning that it's a bad news. You could say something like, sorry, but I have a bad news to share with you. When you're giving medical facts, use simple, non-technical language which matches the patient's comprehension and vocabulary. Consider their educational level, consider their socio-cultural background, their current emotional state, and their age. Right? If it's a teenager and you're telling the teenager, what kind of language are you going to use? So make sure you are, keeping that in mind as well. Don't be blunt in the way you're telling the information. Give information in smaller chunks. Periodically keep checking whether they've understood. And as and when the reactions occur, the patient's reactions occur, respond to them. Also, if there are any positive aspects, give those positive aspects first, always. And otherwise, give accurate facts about treatment options, prognosis, costs, because that's also very important for them. Most importantly, never say there is nothing more we can do for you, because there's always something you can do for the patient. You can always do something to keep them as comfortable as possible. You can give them psychosocial, emotional support. You can do pain management. You can do symptom management. So it's never so that you can't do anything for the patient anymore. And saying that basically takes away hope. So don't do that. Next is explore emotions with empathy. Now, this is sometimes very difficult and challenging. Okay, now one thing I want to make it clear, these are not actually stages occurring one after the other, right? So as you gather and then give information, you will simultaneously be taking in emotional cues as well, identifying their feelings as they are expressed. Now, there can be a range of emotions: silence, despair, disbelief, shock, denial, anger, so many different things that you'll be seeing at different times. Give patient time to express their feelings, then respond empathetically. Don't prematurely try to calm them down. Through reflective empathetic statements, you can, of course, offer your support, your solidarity. Or for example, saying something like, I wish the reports were better, but we will do our best to keep you as comfortable as we can. You're not alone, we're always here with you. Which shows that you are here, which shows that you support them, that you are in solidarity with them. Also, if there is no expression, you can always ask exploratory questions. Let's say, for example, a patient says, oh, so I guess I have to take more chemo again, with a blank face, okay? There's no emotion involved. You can always still respond with, I can see that it's upsetting news. I know you were hoping to go home this week, and then see whether there is any emotional expression that happens, right? Next is strategy and summary. That's the last. Having a clear future plan definitely reduces uncertainty and anxiety. So once the patient has relatively calmed down, ask them if they would want to know and if they're ready to discuss the possible plans of action. Always ask. Again, respecting their wishes. If they do not feel up to it, it's okay. Allow time to calm down and you can always come back later. When you're closing the interview, ensure that you summarize the key points and inquire if they need clarification. As I said, the general framework is what we are doing here. Only thing is in a little specialized manner. So that's the spikes protocol. All right. There are also a couple of others, but we shall only look at two of these: spikes and breaks, which was put forth by some Indian and Nepali professionals 10 years later in 2010. So the breaks was given by Vijay Kumar Narayanan and colleagues, published in the Indian Journal of Palliative Care. This is available online with open access. So is the spikes. I'll share the links for both of these papers with the PPT. Both papers have wonderfully explained the protocols. You can always go and refer to them in a very, they've explained it in a very practical manner. It's not theoretical. It's easily applicable. So BREAKS is again an acronym standing for background, rapport, exploring, announcing, kindling, and summarizing. So background is basically knowing the context of the patient. What kind of a cultural, social milieu is the patient a part of? Their religious, financial, educational background, their coping styles. Basically, it's not enough to know the disease status of a patient before breaking the bad news. You need to have done your homework about whom you are giving the news to, so that you're better informed, also more sensitive and respectful towards the patient. At this preparatory stage, you also ensure that the physical background has been set for the conversation, just like we spoke in setting in spikes. All right, next is rapport. Rapport is going to be very important in determining how the patient is receiving the news. Having a good rapport with the clinician would make the patient feel supported and less isolated in the face of the news. To do this, make sure you don't hurry, rushing to tell. Ask open questions and pay attention. Pay attention to the verbal and the non-verbal cues that you're receiving. Next is exploring what the patient knows about the condition. Take your time to explore their concerns in detail. For example, if a patient is expressing fear or uncertainty while speaking of what they know, don't jump in to reassure. Explore the causes behind the fear. Let them open up and share freely. After that is done, you announce, just like in spikes, with a warning to prepare the patient. Keep your explanations short and easy. Don't get into elaborate, overly detailed, one-sided information giving or telling stories of other patients who have gone through similar ordeals. Please don't do that when you're breaking the bad news. Okay, after this comes kindling of emotions, where again, you need to give adequate time for expressing feelings. Let them cry, let them take it out. Do not lecture or try to give false hope. Most of the times, this is a very selfish action. We do it. When a patient starts crying, we immediately go start consoling or reassuring because we are uncomfortable facing the pain and sorrow of the patient. So we shut them down. And that's very unfair and honestly wrong on our parts if you're doing it with the patient. So let them take it all out, let them ventilate, let them go through that cathartic process. Also, patient might at this stage ask questions. Make sure your answers are on point. Let them be truthful, let them be on point, and let them be shared gently. There is also a chance of differential listening happening at this stage, where patient basically selectively pays attention to only what they want to hear, either only the good or only the bad. So be aware and alert to that possibility and keep checking for understanding so that you know that differential listening is happening or no. And finally, summarize, of course, if possible, give the summary in writing because it is difficult to remember everything in an emotionally overwhelmed state. Summarize all key points and possible courses of action. Let them know you're available for them if they want to share or talk or ask anything, and fix a review. Most importantly, ensure immediate patient safety. Has the patient come alone? Are they driving back? Do they have someone at home who can support them? बता दिया और चले गए, हमारी ड्यूटी खत्म? No, sir. So some of you might be thinking कि ये सब तो ठीक है. I know the sequence of actions now, but what do I actually say? We might just go blank regarding that when the time comes. Firstly, it always helps to do a mental rehearsal. Imagine the scenario, imagine all the possibilities, and imagine what responses you can give in each of these before you go do that interview. Secondly, this is what it would look like in practicality. You would say something like, can you tell me what you already know about your disease? Let us say my patient knows that it's an advanced form of cancer. Okay. I can further say that yes, and unfortunately it is progressing. Now, when I give this much information, I pause, I take in the cues. After that, I give the next chunk of information. At this stage, we're not able to offer a cure. I again pause. I let the patient process all of this. If there are any emotional responses at this stage, I make sure I give space and time for that. Only then do I go to the last part of it, that here are some possible options that you can choose from. Can I tell you about them? And then proceed based on the response. If the patient wants to hear, you tell them. If they don't want to hear, you keep the door open and close the discussion, saying we are always here for you. All right, I hope it's pretty clear as to if you had to do this interview, what would you say and what would you do, right? All right, now regardless of how well we do this, however well communicated, bad news is still bad news. So we need to expect certain possible intense emotional reactions from patients so that we can respond appropriately. The first person to try and talk about this process of grieving and adjusting to bad news and the upcoming consequences of the bad news was Elizabeth Kubler-Ross. You might have heard her name already. and you might be familiar with her work on stages of grief: denial, anger, bargaining, depression, and acceptance. Although for ease of understanding and classification, we put it like this into clear-cut stages, we need to understand that these stages are not linear. They don't come one after the other. They are fluid. So you can have bargaining and then acceptance and then go back to anger. That's quite possible. Or you could have multiple things happening together at the same time. So let's be very clear that these are not linear stages. They don't happen one after the other, and they are descriptive, not prescriptive. She was only attempting to clearly describe what can happen. It doesn't mean that it's prescribed that the patient should move from one stage to the next in a rigid set manner, and that everything other than acceptance is undesirable. That is not so. Each of these behaviors serves a purpose and function to keep the person safe psychologically. They are needed for us to process the bad news adequately. So let us just look one by one. What are these nonlinear behaviors? Firstly, denial, often the first reaction to bad news. This can't happen. You are lying. The test must be faulty. I want to take another opinion from a more qualified doctor. Your team is not good enough. Things like these. Yes, basically the person is trying to shield themselves from considering an upsetting reality. So they often reject the news or they simply avoid the topic altogether. This is a shock absorber for them, right? Now, in the context of terminal illnesses, a certain period of denial is quite normal. And this could actually be quite important to process scary information without facing it in conscious awareness. It turns problematic only when it starts to interfere with treatment compliance or when it delays treatment. Because the patient is in denial, they don't start treatment at all, or they start minimizing symptoms, and they keep insisting on curative treatment when they have been proven futile. These are the cases when denial becomes problematic and we need to deal with that. How do we assess it? First of all, listen to words, but also observe the non-verbal cues. If you find any discrepancy there, that's your opening point. That is where you can get access to them and start managing that denial. Also, very importantly, make sure that the denial is not actually a lack of understanding or a lack of information. These are two different things, right? My patient doesn't know actually what is happening versus my patient knows and is denying it. So make sure that it's not the first one, that it's not a lack of information that's happening. Secondly, check what are the benefits and risks of denial for the patient. Of course, denial has its benefits. If the benefits are more than the risks, the patient is of course going to keep denying. So check for that. If you feel it signals fear, let's say minimizing symptoms is a very classic thing where it signals that, okay, the patient is actually afraid, provide emotional support because that is what the patient actually needs. And very importantly, don't confront directly. It's counterproductive. It doesn't work. You need to keep your emphasis on your continued support and take a very non-confrontative approach. Only then can you manage denial. Next is anger. Commonly expressed by patients as they accept the bad news as reality. Now, this anger could be turned inward or outward, could be in the form of blaming self or doctors or family or even God. Or it can also be undirected to a specific target, only coming out as behavior, a short temper or less patience, etc. So when we are able to recognize it as a natural process, we can then be able to not take things personally. We are then able to tolerate seemingly hurtful accusations and even be compassionate in the face of it. Now, one important thing is anger is what we call the tip of the iceberg. Okay, you all know what an iceberg looks like, right? Only the tip is visible above the sea. Everything else is underneath water and is not visible. Anger is like that. We call anger a secondary emotion. Most of the times, anger is not actually anger. Anger is fear, anger is insecurity, Anger is worry, anger is rejection, helplessness, sadness, shame, so many different things. Expressing them as anger is just easier. And that is why we see anger a lot. So just knowing this itself will also help when the patient gets angry to not be judgmental of the patient. Because then you can start exploring what is it that's underneath. It might indicate underlying helplessness. It might indicate fear, and you need to actually address that before you address the anger. Or there are also times when anger could actually be because of ineffective communication between the patient, the family, and the doctors, in which we need to rectify if that's happening. How do we manage it? How do we manage when there is anger? Most importantly, be direct. Don't beat around the bush. Be simple. Firstly, ask the patient to sit down if they're standing and yelling and shouting. Acknowledge and name the emotion and address their need to be understood. So saying something like, I can see that you're angry. Can we please sit down and talk? I shall try my best to help. If you also get all worked up with the patient being angry, that's not really going to help. It's not taking you anywhere. So you also need to recognize that the anger is at the situation, it's not at you. And stay calm, stay empathetic, and stay relaxed. Give them time to express. Don't jump into justifications or explanations. Let them express their anger. And of course, observe nonverbal cues, because that will give you basically an idea of what could be the primary emotion beneath the anger. And acknowledge their reasons for being angry. When you do this, most of the times patients calm down, because they see that you are not getting riled up, because they see that you are actually willing to help, and you're actually giving them time and space to vent things out. You're not judging them for it. You are not saying that they're wrong. You're not trying to justify yourself or getting defensive. That works. What worsens anger? One is being defensive. Secondly, if you are indifferent to their anger, it shouldn't come as you being dismissive. When I say be relaxed, I don't mean be indifferent or be dismissive. Be present, be concerned, but don't be worked up about it as if you're taking it personally. Another thing that can worsen anger is if you start blaming the patient, ulta. Or if you block the patient completely, you leave them feeling unheard. Yes. So even when you prematurely start reassuring, you are still blocking the patient because you're still leaving them unheard. The next step, we were looking at denial, then we looked at anger. Now we are looking at bargaining. Okay. Bargaining is basically when patients try to, start to have some amount of control over their condition. So they start negotiating. They start negotiating about treatment adherence, or about accepting help from others, or even something like if they feel guilty about something. For example, I treated my children very badly, okay? And then I say, God, I promise I'll be a better father if you cure me. That's bargaining. And you don't need to repeatedly correct it in any way, but also don't participate actively in it, because that can be very misleading about how much is actually in your or the patient's hands. Don't give them that false sense of control by actively engaging in that bargaining in any way. After this is depression, very obvious and most easily recognizable. Probably the previous stages or all the previous behaviors are actually, or could be, an unconscious effort to protect oneself from the emotional pain in this stage. And again, depression will be very easily recognizable, very typical signs of depression, nothing atypical. So you'll see that people are crying, you'll see anhedonia, You'll see sleep fluctuating, like disturbed sleep or increased sleep, things like that. And lastly comes acceptance, which is basically recognizing the reality of the diagnosis, but not struggling against it in any way, and focusing on living the most in the time that's left, preparing mentally as well as practically to say goodbye. That's acceptance. Here again, I would, when I say that these stages which we saw, right? Let me just go back to this, okay? As I said, they're not linear. So let me just tell you what I mean by that. We had a patient who was unresponsive right from the time she came to us. We knew that there was not much time left. She was deteriorating day by day, completely unresponsive. And so all we did was try to keep her comfortable. Now she had her husband and her daughter, young daughter, who went to college. Now in all of this, when I went to meet this patient's family the first time, only the daughter was present. Then I got to know from her as well as the nurses on duty that she was the one who was taking care of everything. The daughter was the one who was taking care of everything. The patient's husband was completely missing from the picture. Then I got to know from the patient's doctor that actually her father was extremely attached to his mother. They worked together as well as were husband and wife. So they practically spent the entire day together. It was a love marriage which had happened against societal and family permissions. So of course they had seen a lot together and they had this small happy family of theirs. And the husband basically was completely in denial. He was not ready to come see the patient at all. It was the child who had got her mother here. It was the child who had gotten her admitted, completed all the formalities, would stay with her mother, look after her mother, get medicines, everything. And he would not come. 2 days later, he came for the first time and he was angry. Okay. He was angry. He was shouting at the patient. He was yelling at the patient who was unresponsive. Okay. And he kept shouting at her because he was angry that she was not looking at him or she was not talking to him. And he kept expressing that anger of his a lot. And he again disappeared for 2 more days. Now, this was when we were like, no, we have to, this is high time. First of all, we don't have time with this patient. On top of that, this is the family condition and we need to do something about it quick. So I was always constantly speaking with the daughter, of course, and the daughter had always been in acceptance. Okay, she was, whenever I saw her, she was not in denial, she was not in anger, she was not in bargaining, not depression. She was in acceptance. She knew that her mother was going to go soon. She was just doing her best possible to keep her okay till she was here. Now, what happened was there was this sudden shift which we saw the day the patient passed away. Before the patient passed away, actually, she passed away in the afternoon. I had gone there in the morning. The child's father had come in the morning. He had directly shifted from anger to acceptance. There was no bargaining, there was no depression in between. There was denial, there was anger, and then suddenly there was a shift to acceptance, where he was the one who was taking care of the child, who was telling her that, it's okay, whatever is going to happen for the good, because she's going to be at peace and she's not going to be in pain when it happens. That is what he kept telling her. And this was when the child had actually moved from acceptance to depression. And she was crying and she was just not at all, in a good state, in a stable state. And when the patient actually passed away, the husband of the patient still stayed in acceptance, and the child had moved from depression to denial. She was shaking the mother. She was asking her to wake up. She was asking her to, so it's very fluid. It's not very linear. It's just for us to understand that these are the things which can happen when patients have to face bad news, so that we are prepared to respond accordingly. Yes, all right. So yes, that's it from my side for today. I would actually like to end with a quote because it made very much sense to me. We cannot change the outcome, but we can always affect the journey. Any questions? Any doubts?
Dr. Mukta, if you can hear me,
Yeah.
and if it's clear, you had mentioned about Adonia. What does that mean?
Anhedonia. It's a lack of pleasure.
Okay. Anhedonia,
Yeah.
which is the lack of pleasure.
Yes. Happens in
Not
depression.
feeling.
Huh.
Okay. Okay.
Mukta, that was indeed a very explained session. So if you have any pressing questions, you can ask right now.
I have a question. Somewhere in one of your slides, there was something ethical and legal. What was that reference to? Did I miss hearing that?
No, it was about collusion, I guess.
If you can go back to the slides.
Yeah.
Presenters.
Yes.
Probably it was the second, before we did the spike, before we did the breaks. It was way before that. Somewhere, or did I read it somewhere else?
No. This one.
Yeah, ethical and legal obligations.
Obligations, yes.
Yeah, if I missed, or you can just explain that, why
Yeah,
it's important.
basically, first of all, it's ethically only right that we tell the patient has the right to know their diagnosis and their prognosis.
And
So-
legal obligation, do you mean with reference to the will and all that, the procedures?
No,
Then-
not will, actually a legal obligation for us to tell the patient.
Okay, it's legal, or it's an obligation for the
For
hospital,
the treating team,
for
to
the
let
treating team
patients-
to keep them
yeah.
posted.
Yes.
Okay. Okay. Thank you.
Thank you, Sheetal. So we have a question from Lakshana. Could you tell us something more about patients' right?
Patients' right?
Patient rights. That's what Lakshana mentioned.
Yeah, patient rights.
Patient rights as in patient rights. So whenever I have mentioned patient rights, it's basically patient rights to know the diagnosis, know the prognosis, know the treatment options, and the right to choose from those treatment options.
Okay. So is this something that is brought up by the medical team first? Because I'm assuming a palliative team would come in a little later, but a patient's right to information and understanding of their treatment, etc., would begin right from
you begin
diagnosis.
right from the starting. Yes.
Okay. And in your experience, at least in my experience, it doesn't seem to be something that a lot of patients even know of or ever really comes up in a.
Yes.
So how can this be something that more people are made aware of? Because again, a lot of the times, the patient, I mean, there is an inequality of information between the medical team and the patient and family, right?
Absolutely. Yes. Yes.
And so very often the patient and the family tend to accept what is told to them as the only option. So where are these patients' rights talked about at all? I mean, and is there a way to get more people aware of them right from the beginning, not, towards the end where the palliative team comes in and lets them know that they have patient rights?
Yeah, I think it's only up to us who are in the field to,
Mhm.
as of now, I don't see any collective efforts. So, to
Mhm. Okay.
but individual efforts, yes, people are taking, but that's very limited, only limited to our individual reach.
Is this available somewhere on the internet, perhaps? I mean, I'm just asking because
Yeah, I
uh,
get your point. You can share it with patients or something like that. I'll
yeah,
just check if something which is easily, comprehensible and accessible, if I can find something like that, I can definitely share it with everyone.
yes, please. Thank you.
Yes.
And also we have a question from Mr. Rajesh. So can you speak up? Mr. Rajesh, can you speak about your question?
Okay, I'm reading it. Just a second. With reference to strategy and spikes, should differential listening be accounted for by preparing for a differential response when posed with the same certain variables that need to be accounted for when for a while strategizing since such a contingency is ad hoc. Hello, so are you there? Hello.
Sir, can you unmute and speak?
Hello.
I think sir is only available to the chat box.
Oh, okay. Okay, so I actually have wanted you to unmute just because I needed a little clarification on your question. So when you say reference to strategy in spikes, should differential listening be accounted for by preparing for a differential response? May I know what you mean by a differential response?
I think sir is typing. We can wait for another few seconds, Mukta.
Okay, okay, fine.
May I put in a point in that time if I am right in those terms? Am I audible, Dr. Mukta?
Yes, Sheetal.
Yeah.
Yeah, I think Shana had asked about the patient's rights. If we go back to our person with disability rights, would that rights match up over here? Because there are a few rights which are mentioned in the charter wherein it says like, the patient has got certain rights to know few things or to like have the choose things or to deny things.
I'm not very sure if we can just directly apply them in this context, actually. I'll have to check up on that. Hello? Your voice is breaking.
Hello, can you hear us now clearly?
Can I be heard? Is it good, better? Voice quality?
It's still breaking only. The sound is still breaking only.
Okay. I will try to chat. Basically, I had a bad internet and somewhere outside. Okay, maybe you can take up Mr. Rajesh's questions first. He's back.
Yeah, with response to Rajesh sir's question, okay, I think he has typed a response. Lessons which may make the speaker deviate from the strategy should be selected approach video speaker as well. Oh, okay. Okay. No, actually, what I meant by differential listening is So I'm giving out information, right? And I'm telling the good as well as the bad, whatever is applicable in that particular given situation. If my patient is only catching hold of the good, okay, this might not readily be, I might not readily identify it unless and until I check. So I need to keep checking what my patient has understood. If my patient is telling me only the positives, I need to make sure that I'm repeating. And I'm going back and I'm telling them that, yes, this is true, but XYZ. So you don't really need to deviate from the strategy, so to say. And again, when we say original strategy, it's not really a rigid fixed structure. Strategy is basically, if you go to see, oh, I stopped sharing, just a second. So when we talk of strategy, we actually give them multiple treatment options or treatment plans, and then we ask them. So it's a collaborative decision making. It's not unilateral. It's not me telling the patient that this is what we are going to do. So it's not a rigid fixed thing. There are options and the patient gets to choose. Strategy and spikes. Of course. I will be sharing both the original publications are available online, as I said. I'll share those as well. And then you can go through that in more detail, probably.
Thank you, Mukta, for that. I think we can move on to the case presentation right now.
Okay, sure.
I invite Ashley to present the case presentation. Ashley, to over to you.
Yeah. Am I audible?
Yes, you are.
Okay. Yeah, we can move ahead. Yeah, so here the patient is 26 years old. It's a male. And they are diagnosed with Bell's palsy, which is basically paralysis on the face, but the half side of the face. And they have a repaired fractured femur, that is a reconstructed, the bone in the thigh, basically. And they have a form of amnesia that they are going through. The occupation is that they were interning with a sales representative, as a sales representative. The medical history is they were diagnosed, as I said, with the facial paralysis thing, which is called Bell's palsy. And they have a reconstructed femur, that is the thigh bone, and a form of amnesia. This happened after an accident when the patient met with in Goa, and they were transferred to Goa Medical College. And then the caregivers were informed that the patient had trauma to the head, that is which caused the facial paralysis, and also the fractured femur was due to the entire accident bit. The subject, then the patient was, they were told that they had to medically induce them into coma, and it was required for the intermediary nailing, that is for the surgery of the thigh bone, basically, to reconstruct it. And post-surgery, the patient was still, medically induced and in coma. So it took the patient 2 weeks to get out of it. During that time, the patient's leg was still plastered. And during this time, when he gained consciousness, he was still a bit aggressive, because he in layman's term, you'd say he's not in his senses completely, but he would screech because he was still in pain due to the surgery, and he didn't know what was really happening during that time. As he completely gained consciousness, and was able to understand few things going around. It was already the 4th week, but due to his amnesia, he didn't know, he didn't know the timeline, like what happened, like when the accident happened and whether it was post-accident. So he couldn't gauge where he was during this time. And he had a lot of memories jumbled up, but a few episodic memories. Like all he could remember was who he was, that they came to Goa for a vacation and things like that. Then he also had a little bit of disorganized speech because of the Bell's palsy, because he couldn't speak clearly, and he kept you could say he was in denial due to the word accident. He didn't like it. And weeks later, the patient was taken back to Mumbai, which is his actual home where he lives. And the follow-ups with the doctor was done in Mumbai. And even follow-ups regarding his entire surgery bit, because there's a rod in the thigh basically. And he was told to go and follow up with a physiotherapist. And what was told to be done was the TENS, the kind of heat electric thing to the muscle that's given, that's called TENS. So that's given on the thigh bone, near the thigh during physiotherapy. And the patient is now better, but still limps and still finds it difficult to walk. He still has Bell's palsy, which is the facial paralysis thing, and has a slurred speech right now. His memory is not reliable, as in you still can't rely on him for too many things regarding his memory. And his food intake is low, and he gets impulsive and frustrated due to the condition he is in. Yeah. So as for the insight part, as for the diagnosis, the patient's family definitely had more insight and continues to have more insight. Whereas for the patient, he finds it slightly difficult to accept in regards with the memory bit, because he does not like to be told that, and he understands only the surgery thing that happened to him, and he does not understand the part about the Bell's palsy, that is the facial paralysis. As for prognosis, he is definitely in denial, as I mentioned, regarding the memory aspect. And he knows about his condition regarding his thigh and knows that physiotherapy is needed. He is aware of the Bell's palsy, but he has no idea what's next regarding the facial paralysis. As for the family, and which consists of the mother, the father, and the father and the brother are pretty optimistic about this entire prognosis, but the mother is still in denial. And as for palliative care, the patient does not understand what it is, and the family understands palliative care, and they are looking forward to it. So this is the genogram, and so P on the right is the patient, who's 26. He has a brother, which is the alphabet E, and his brother 17. His father is 48. His mother is 45. The two on the right, 48 and 42, is his mother's sisters. So his relationship with his father is good, and I may have missed this out, but his relationship with his brother is slightly conflictual, which is represented with the red dots. And his mother and his sisters don't get along well. At the same time, his mother and his sisters are pretty controlling towards him, and this is where you'll see forward that there's some effect on his lifestyle. And his mother is pretty controlling towards the other brother as well. But the relationship between his parents are pretty good. And since he's medically, he has medical issues, the patient square is marked with those dotted lines diagonally. I think we can go ahead. Can we switch to slide? Okay. So this is just the overview. So the patient's Christian. He was actively interning as a sales representative before the accident. He currently lives in Mumbai. The patient has conflict with his younger brother, and the mother controls the children based on her desires, even in regards of what's in the future, and what job or opportunities they should be looking for. Post-accident and the surgery, the mother indirectly implied that the patient should still be going to find a job, which in turn didn't help him much because he was still recovering and going through the stages of grief. The patient was advised by the doctor against moving out of the house, regardless of the job situation, as it was more of a medical rehab requirement, and his state of mind, as mentioned earlier regarding memory, was not reliable. And the father works in Daman and only comes to Mumbai on weekends. He has a great relationship with his wife and his children. The mother and her siblings don't really get along well due to past financial conflict. And as I said, the mother's pretty controlling of her children, especially the elder son, and because she considers him to be the next provider for the family. And the sisters get into conflict because they want the patient, that is the boy, to follow their ways than his own mother's ways. And the patient was trying to complete his job placement requirement during this time and find ways to get a job. But during this time, he also got scammed twice while he was searching for a job opportunity. And even after trying to work for a month, they didn't pay him. So this is another thing that's brought his confidence down and caused him low self-esteem. During this time, he also resulted in getting frustrated and having arguments with his brother. I'll mention further. So next slide, please. So this is the eco map where the patient and the family is in the middle. And so they have basically this it's stressful conflict between the extended family and them. Their stress towards the stress towards finance is pretty high. And in regards to patient and family, towards the counselor, the patient isn't doing really well with the counselor because he does, as I said earlier, he does not even understand the need for palliative care. So that's why he finds it stressful with the counselor. In regards with religion, it's gotten pretty weak. And in regards with physiotherapy, it's pretty strong because the patient as well as the family has seen, him moving from being bedridden to at least limping and moving further. And it's also helped his Bell's palsy. And he has a few college friends where there the relationship is positive. In regards with job, due to the scam and due to not being able to get one because of his condition, it's been really weak, the relationship, but he still looks forward to wanting to get a job. We can move to the next slide. His socio-economic overview would be they live in a tiny one-room kitchen in Mumbai, which is managed by the mother and father. And they are in a low socio-economic status as such, because financially, and the only ones earning are the parents. The patient is unable to work due to his diagnosis in present, and the sibling has not yet completed his 12th and is preparing for his boards, which is the other thing that they see as a burden to pay for. And the physiotherapist expenses are pretty high, and so are the follow-ups regarding the post-surgery regarding his thigh. And the father works in Daman and visits the house only on weekends, which does not help much. And brother's education is yet to be completely paid for. And the mother and the sisters already have a stressful relationship with finances, which means they're still in loan as such. You can go to the next slide. The psychological overview would be the patient is under duress in regards with how to help his family financially, because he knows he's the next one to be helping with money. And there are quite a few stresses, like he blames himself for the circumstance that he has put his family in, because he thinks it's because of the accident and him that that they will now not be able to get money, and he can't help them at the same time. And he blames the job placement requirement needs not being met again on himself because of his condition. And he does not like the way he looks because of his facial paralysis. that is the Bell's palsy, and the combination of loss of control and having no his identity is pretty much a question mark right now, and and having to provide for the family has caused the patient to feel depressed and lose a sense of purpose at this point. Along with this, it has caused him to express a lot of frustration in the form of verbal arguments with his brother. There may be smaller arguments, but there are also arguments with his mother. As the mother and aunt are controlling, he feels pressured into listening to their way of life and what has to follow. And he's not able to choose for himself. There is a huge regret in regards to having met with the accident, basically. You can go ahead. So the total pain aspect is in physical. I'd go from physical. So physically, he's in a limiting, he's in a limiting condition. He has the Bell's palsy and a reconstructed femur, and it's a problem because of the mobility. He can't move. Psychologically, the total pain aspect would be future capability stress, identity crisis, which he has, and anxiety. Then the stages of grief, which I would say not just him, but also his family is facing in a way. And there's behavioral issues that we can see happening. There's frustration, and the mother's psychological well-being, because this is accounted for in total pain, and lack of boundaries, I would say, between among the family members. And then socioeconomic status low, then financial crisis, and the entire bit of having acceptance within the society again goes forward to the entire family. And spiritual aspect, the decline in faith in religious community. He does not know if there's hope for his future, and he finds a lack of no sense of purpose in spirituality at this point. So these are the discussion points I put down. I don't know, should we be going through them one by one, or should I read them out, all of them?
I think most of them are being taken in the session itself. Is there any pressing questions you want to ask Mukta, which is unanswered yet?
Actually, I had a question, Ashley.
Sure.
I just wanted to know, I mean, you haven't
Yeah.
mentioned it, so I'm assuming it hasn't happened. But by any chance, was there a neuropsych evaluation done?
Yes.
Okay.
Yeah. It was done during the time, before transferring from Goa to Mumbai.
Oh, okay.
And then another follow-up was done once in Mumbai. Sorry, I did not mention it.
Okay.
Yeah. And
No,
I
I
also
haven't-
didn't really have much access to that.
Oh, okay.
Yeah.
Okay. All right. Because with regards to that, with the memory issues,
Yeah.
if there was any neuropsych evaluation done, if there was any rehab planned, that would have definitely helped. So I was
True.
just wondering about that.
Yeah. As far as I know, by speaking to the family members, what I know is that they say that they're just calling it, a type of amnesia, but he's regaining his memories back. So each day that's passing, each week that's passing, he's remembering things, but he's not able to place them on on the timeline. He's not able to place them in the correct time.
Okay.
Yeah.
Also, there's one more thing. I know you have already mentioned again that his relation with the counselor is very stressful, but actually, given his condition right now, he would really benefit from, especially from third wave psychotherapy. If there is somebody who can do ACT or something, that would really benefit.
Could you elaborate on that?
Yeah, acceptance and commitment therapy.
Okay. Yep,
Yes.
Yep. The one you mentioned. Yeah. Right.
That will definitely help, given the fact that, and also one more thing is, if he, I understand that he is not very much ready to speak with the counselor, but what about the family?
The family wants him to speak to the counselor. Yes,
No,
but
but
I
the
don't.
family ready to like if the counselor is going to suggest a few things to the family, would you think that would be possible?
Yeah, that's not happening. That's what the family doesn't want it for themselves, or doesn't want to be involved within that. They just think that it's him that needs to change.
Okay.
Yeah, that's
Okay.
where that's where the stress is also like with the family. It requires I mean, this is how I saw it. I think
Mhm.
the family also requires to be part of whatever the change that needs to be
Of
there.
course, yes.
That's the major bit.
Mhm.
Yeah.
Have you, or I mean, whoever is dealing with the case, have they tried to build insight in the family about why it's a systems approach, why it's not an individual that we can treat, and we need the entire family to cope up with this?
I'm sorry, I lost your voice a bit.
Yeah, can you hear me?
Yeah.
Okay, so I was saying, is it possible by any chance to, or have you or whoever is dealing with the case has tried to build insight into the family about why it needs to be a systemic approach, why we can't treat an individual and it's a thing which the entire family has to cope up with, this whole thing, the accident?
Okay, I mean, I've written it from my like this bit from my perspective, where I know that because there's a lot of the do's and don'ts from from the mother's side.
Mhm.
There's a lot of controlling in the sense that don't do this, don't do that, because we want you to get a job.
Mm.
So it's what's been seen by the family is like, oh no, you need to go and get the job. You need to come and get ready to provide, regardless of, like mentioned earlier, he was
Mm.
supposed to still be at home and get his rehab done, but they still pushed him for like to going and trying to get the job. Whereas doctors mentioned like he needs to stay at home.
Mm. Yeah.
So
This
sorry.
this is really an unfortunate thing that is not ready to speak with the counselor, because the
Yeah.
entire solution lies there actually.
Right.
Anybody
It took-
else have any inputs where you would like to suggest something different where we could somehow indirectly get them to be more cooperative, basically? Anyone?
Something like a family therapy would help also, like they all sit together.
Of course it would, yes. But that's the problem. The problem is they are not ready
They're not
to.
sitting on the same plane, like they don't want to be there in the same talk, the discussion board types. They don't want to be there in that same discussion,
Right.
right?
Right.
Since he is getting some good results with physiotherapist, could that person take a lead and do some kind of a mediation, or that's none of his business, his or her business? Because there is something strong happening. That's the only strong line that is seen. Because he's also in a with therapist, counselor is also in a with therapist. So can't they both sit together and try to explain to the family or to the individual, whichever way? Would it help?
I'm not sure. And is this question directed towards me or Mukta ma'am?
This is a suggestion. So
Suggestion. Okay.
yeah.
Okay.
So would that work? Yeah, it's a question to Mukta ma'am, because you
Okay.
have put forward the situation.
That
Ma'am.
depends on what kind of a team we are working with.
Yeah, because we had that. Yeah, we had that one session on the entire team working towards a
Ideally.
goal.
Yeah, no, that's
Probably
what.
if We are
So,
looking.
you know, that is why I said it depends on what kind of a team we are working with. Is it a physiotherapist coming from a different center and a counselor coming from a different center altogether? It won't work.
Yes, it's different center.
If it is one
Okay.
place, one center which is providing multiple services, then we can think of the possibility, we can talk about
Uh,
how the physiotherapist can mediate somehow, or at least get him a little ready to talk to the counselor, and then the counselor can take it through something like that.
Also, in that entire family chart that was shared, it seemed
Yeah.
to be that the father is having the most number of green lines radiating.
Yeah.
So
Yeah.
probably father can take any kind of an initiation which the son would listen to, or which can father be the bridge to bring them on the board.
That's actually a good suggestion.
Possible.
I don't
Yeah,
know. Would it
that's a
work?
good suggestion.
Because he's the only one who's in harmony with everyone around.
Yeah.
I don't know about with the sister-in-laws. Probably that can help because he knows the situation, he knows the patient, he knows the physiotherapist and the counselor. So if it helps.
Right.
So Ashley, slightly irrelevant here, but can I just make a technical change in the
Yeah.
family overview?
Yeah, sure.
You need a vertical line in between the mother and father to the children.
Okay. Okay, in between.
And
Yeah,
you,
yeah.
and you need the elder son before the elder son has to be on the left.
Okay. All right. All right.
Yeah.
All right. Yeah, actually, yeah. Okay. I had done that. I was finding it really difficult to draw the relationship between the aunts to the elder son.
Okay.
So that's why I switched.
Okay. Okay.
But yeah, that's good to know. I didn't know the technicality behind that.
Okay. Yeah.
So that's good.
All right. Anybody else?
In the whole thing, I don't know if I missed who holds the finances.
Who holds the?
Who's the one who's a financial decisions? What goes and what comes and how much of treatment is paid for? Financial decision who takes?
Financial decisions. That's the mother.
Mother and father both are earning, as you mentioned.
Right.
And
The
son is
decision
about
maker-
to earn, or he was on that brink of earn.
Right. The decision maker
Is
right now
mother.
is the mother.
Is the mother. Okay. Then I guess first task is that the father should convince the mother, who is not in that good terms with both sides. Okay. It's very okay. That's the case. That's how the cases are, I guess. Thank you.
Yeah.
Yes, I think Sheetal ma'am's suggestion is really wonderful, that you get the father on your side and you just try sorting things out from there.
Right. Right.
Yeah.
That is true. That is true.
Any more suggestions or anything else? I think we are done.